Welcome to this explainer on managing severe malaria in the emergency department. Look, if you're an emergency physician, an intensivist, or an acute care internist, recognizing a crashing patient is just what you do every single day. But severe malaria, it's a total master of disguise. It demands a complete 180 from our usual resuscitation playbook. So today we're focusing purely on high-yield, actionable clinical pearls drawn straight from the latest guidelines and critical care literature to help you manage this literal, life-threatening emergency.
Okay, let's quickly run through our clinical algorithm for today. Epidemiology, pathophysiology, recognizing severe malaria, diagnostic priorities, emergency management, and finally, disposition and takeaways.
Let's jump right into Section 1, Epidemiology and the Global Scale.
We've got to anchor our clinical suspicion in the data first. The thing is, the highest risk of mortality often falls squarely on non-immune travelers returning from endemic areas. Because they lack that acquired immunity, these patients can deteriorate incredibly fast when they roll into our non-endemic EDs. To put the sheer scale of this into perspective, there were an estimated 263 million cases of malaria globally in 2023. I mean, that is a massive global disease burden. In short, transmission was eliminated in places like the US decades ago, but the ease of modern global travel means those millions of cases are literally just a single plane ride away from your triage desk.
The data brilliantly illustrates the risk zones here. 94% of all global malaria cases occur in Africa. Basically, this means if you have a returning traveler presenting with a fever from these regions, they require your immediate, undivided attention. Just to highlight this, Nigeria and the Democratic Republic of Congo alone account for a staggering percentage of global cases and deaths.
All right, moving on to Section 2, Pathophysiology. To understand why our standard, reflex-driven sepsis protocols can actually be deadly for these patients, we have to talk about microvascular obstruction. Plasmodium falciparum infects red blood cells of all ages, and these parasitized red blood cells physically alter. They exhibit cytoadherence and rosetting. Basically, they stick to the endothelium of your patient's microvasculature, effectively packing and blocking the vessels. It is essentially a microscopic plumbing issue right at the capillary level. This sequestration causes profound tissue hypoxia, metabolic acidosis, and drives that massive multi-organ failure we see clinically. So it's not just systemic vasodilation like your typical bacterial sepsis, it is a physical barrier to perfusion.
Section 3. Recognizing severe malaria. The absolute crucial point here is distinguishing early on between a patient who just has uncomplicated malaria and can safely tolerate oral meds versus one who is critically ill and needs aggressive IV intervention. Uncomplicated malaria often presents super vaguely. Your patient might have lethargy, a fever, pallor, maybe a bit of splenomegaly. Honestly, it looks an awful lot like the flu or just a routine viral illness. But severe malaria is a whole different beast. It rapidly progresses to altered mentation, ARDS, moderate to severe jaundice, and bleeding diatheses like petechiae.
All right, mental screenshot time for everyone working in acute care. If your patient meets even one of these World Health Organization criteria, we're talking a GCS under 11, a lactate over 5 millimoles per liter, severe hypoglycemia, a hemoglobin under 7, or a parasitemia burden greater than 10%, you are dealing with a massive medical emergency. Multi-organ failure is imminent, or hey, it's already happening.
Up next, Section 4, Diagnostic Priorities.
Look, in severe malaria, time is tissue. Delaying antimalarial treatment is an explicitly recognized leading cause of preventable mortality. Now, you have two main diagnostic pathways. Light microscopy of a blood smear with a GIM stain remains the absolute gold standard because it not only confirms the species, but it actually quantifies that lethal parasite burden. And as that burden goes up, so does mortality. But if microscopy isn't immediately available, go ahead and use the Rapid Diagnostic Test, or RDT. It detects antigens fast, though keep in mind it's only qualitative. But here is the golden rule. Absolutely do not wait for these diagnostics to return before treating an unstable, critically ill patient if your clinical suspicion is high.
Let's hit Section 5, Emergency Management and Pitfalls. This right here is the meat of this explainer, the immediate, aggressive management of the decompensating patient, and frankly, the common pitfalls that even seasoned ER docs fall into. Your immediate treatment cascade is simple, but it is rigid. Step 1. Push IV artesunate at 2.4 milligrams per kilo immediately. It is the treatment of choice. It provides rapid parasite clearance and yields a significantly lower mortality than quinine. Step 2. Aggressively manage hypoglycemia with dextrose boluses. It's super common and highly recurrent in these patients. And Step 3. Halt your usual sepsis reflexes and initiate a highly restrictive fluid strategy.
I really want this next rule to disrupt everything you usually do for hypotension in the ED. Routine rapid fluid boluses of 30 cc's per kilo are strictly contraindicated here. Iatrogenic fluid overload is a leading cause of death in severe malaria.
Remember that altered capillary permeability and endothelial dysfunction we talked about earlier in the pathophysiology? Well, because of that, standard fluid boluses are just going to push the patient straight into pulmonary edema and ARDS. You have to balance the risk of acute kidney injury with the extremely high risk of cerebral and pulmonary edema. So, if the patient is hypotensive, evaluate them on a highly individualized basis. Use only small, cautious boluses and reach for early vasopressors to support their blood pressure instead of massive volume resuscitation.
Oh, and here's a quick clinical trap to avoid during your evaluation. Do not let a normal temperature provide you with false reassurance. The absence of a fever absolutely does not exclude severe malaria in a returning traveler who is presenting with signs of multi-organ failure or shock.
Finally, Section 6, Disposition and Takeaways.
Let's wrap up with how we safely transition this patient out of the ED and consolidate these clinical pearls. Any patient meeting severe criteria needs immediate admission to the intensive care unit. The risk for recurrent seizures, crashing glucose levels, worsening metabolic acidosis, and delayed onset ARDS requires constant, meticulous monitoring. And you definitely need to involve your infectious disease specialists as early as possible to help with ongoing drug regimens and monitoring for recrudescence.
Here is a final checklist. It basically summarizes everything we've covered today. Start your IV artesunate ASAP. Restrict your fluids and use pressors early. Check your baseline labs to identify those WHO severity criteria. And never, ever wait for the lab to tell you it's malaria if the patient is dying right in front of you. So I'll leave you with this provocative thought. If that next undifferentiated, hypotensive traveler rolls through your ambulance bay doors today, is your department truly ready to override your automatic sepsis reflexes and give them the highly targeted care that will actually save their life?